Do you think Dave planned it, that the woman who's halfway through pregnancy is giving the next talk? Thank you for being here this morning. It really encourages me a lot to even walk in and see the variety of license plates outside. You've come from far and wide, and I feel really privileged to be here in front of you to speak today about the heart issues that go along with Friedreich's ataxia. As Dave mentioned, I'm a cardiologist, so a simple plumber. I'll try not to speak too fast. I apologize for the lack of handout in the packet that you got today, but my slides certainly can be made available with the rest of them. Let's see. All right, just a couple of disclosures. First, I really have no relevant conflicts of interest to disclose, but I'd certainly be happy to entertain any of your funding offers. And second is just a reminder that I am a pediatric cardiologist, and so I speak from the clinical experience of working with mostly children, so mostly in the newborn to 18 or 19-year-old age range. So my perspective may be skewed because I have a pretty optimistic outlook on how people are going to do with Friedreich's ataxia and involvement of the heart. And I'm going to try to speak on a broader perspective today, but the patients that I see are mostly young and are mostly doing well. And I really hope to keep transitioning my Friedreich's patients to adult cardiologists in tip-top shape. So what do we now know about Friedreich's ataxia and the heart? Well, we've known for a while now that heart involvement is eventually evident in most people who are diagnosed with Friedreich's ataxia. And the most common manifestation is a hypertrophic cardiomyopathy, which I'll abbreviate in all the slides as HCM. We see both variants of hypertrophic cardiomyopathy that are described in the literature, so both those who have concentric thickening of the ventricle and those who have asymmetric thickening of the ventricle, and I'll show you a little diagram that illustrates that. Sometimes, however, the cardiomyopathy can progress to a dilated cardiomyopathy and can be accompanied by symptoms of heart failure. And finally, arrhythmias have been observed in Friedreich's ataxia patients with or without the visual manifestation of thickening of the heart. I'll say anecdotally, it seems to me that the hypertrophy tends to appear by or during adolescence, and that the dilation and sometimes that poor function where the ejection fraction is starting to go down seems to show up after adolescence. So unfortunately, we don't really know exactly why Friedreich's patients tend to develop cardiomyopathies. Some of the proposed mechanisms include things that you've already heard about this morning, so iron accumulation or iron imbalance at least between the cytosol and the mitochondria, a lack of functional iron-sulfur clusters, mitochondrial respiratory chain dysfunction, and oxidative stress. Of course, going back to what Giovanni had presented this morning, the heart, of course the most important organ in the body, is one of the highest energy users in the body. And mitochondria being energy-producing organelles in the body, it makes sense to me at least that when the mitochondria don't function well, the heart is particularly affected. And so that to me is how I understand why is it that the heart seems to be so affected in Friedreich's. Now, I mentioned that I'm a pediatric cardiologist, but I do keep in mind some of the more sobering statistics that have been put out, both in the past and then recently by my colleagues last year. They all speak to the fact that, unfortunately, it's cardiac causes that are listed as the most frequent causes of death in people who have Friedreich's ataxia, and that's hits very close to home. In this study it was a retrospective study that was put out in 2011, they purported that at least 59% of Friedreich's deaths are due to cardiac causes. And as you can see in this bar graph, let's see if I can get, oops. Here we go. This bar graph over here, it's kind of small to see, but what it demonstrates is that the majority of deaths in Friedreich's ataxia occur between the ages of 16 and 45 years. So despite my pediatric perspective that Friedreich's patients do relatively well, I can't lose sight of the fact that as my patients are transitioning to adult cardiac care, they're already in that statistically highest mortality period of their lives. Here you have about a third of patients who've died in this cohort with Friedreich's were between 16 and 30 years of age, and then another 15 to 17% in that 31 to 45 year age range. Here we just have an illustration of what I mean when I speak about hypertrophic cardiomyopathy. Now, when you hear about HCM in the media, typically what people are referring to is hypertrophic cardiomyopathy that's due to a sarcomere gene mutation. That's a different disease process than the hypertrophic cardiomyopathy that's due to metabolic or mitochondrial mediated disease processes like Friedreich's, but visually they can appear the same. So here you have a normal heart with the right atrium, the left atrium, the right ventricle, the left ventricle, and the ventricular walls here, you see this is what normal thickness would be. Comparatively, the walls here are thickened, and you see that leaves less room for the ventricular chambers to accept blood into them. I mentioned also that you can see both the concentric versions of hypertrophic cardiomyopathy and the asymmetric versions in Friedreich's. The septum oftentimes is the area of the heart that's most affected in asymmetric hypertrophic cardiomyopathy, and that's the thing when it thickens excessively can cause what we call left ventricular outflow tract obstruction. So if you imagine my pointer is a red blood cell coming back from the lungs to the left atrium, then coming down to the left ventricle, and it wants to get out of the heart by the aorta. But if this septum is getting so thick that it's impeding my progress out of the heart, you can imagine that that's asking the heart to do extra work. And over time, that can be one of the causes of heart failure in a hypertrophic cardiomyopathy patient. So what are the clinical manifestations of hypertrophic cardiomyopathy? Well, the cardiac signs and symptoms in Friedreich's typically occur later in the course of the disease, but they may rarely precede the neurologic symptoms. And the symptoms we most often see are shortness of breath, especially when one's trying to exert themselves, and chest pain. There are some studies out there that suggest that the frequency of cardiomyopathy increases with the size of that triplet repeat length on the shorter allele that we heard about earlier. And there are some studies, I didn't mention them here, but some studies which have suggested that the cardiac and neurologic severity in Friedreich's don't necessarily correlate with one another. So some people with Friedreich's, and you may know this well yourselves, who have relatively severe neurologic effects may have relatively mild cardiomyopathy and vice versa. So if I've got a hypertrophic cardiomyopathy, what medicine should I be on? That's often what people want to know when they come into the clinic to see me. And unfortunately, in 2012, I can't tell you that any medicines have been proven to be of benefit in someone who's asymptomatic and doesn't have any significant outflow tract obstruction. So I suppose that's good news for the person who doesn't like to put a lot of chemicals in their body. But right now, bad news in that we don't have proven interventions that are going to necessarily increase survival in the pre-symptomatic patient. However, if significant outflow tract obstruction is present, one should consider medicines including beta blockers. So those are medicines like carvedilol or metoprolol. Medicines like calcium channel blockers, so that's verapamil is the most common of those used. And disopyramide, which is traditionally been used as an antiarrhythmic, also has properties which seem to help relieve outflow tract obstruction in some patients. Now, in those who have symptoms, one might also consider beta blockers, again, carvedilol, metoprolol, and related medicines, and calcium channel blockers like verapamil. And then finally, if someone has cardiac arrhythmias, certainly there are medicines that can potentially help control arrhythmias, but also at the same time, if someone is recognized to have abnormal heart rhythms, that's a time where consideration for an implantable cardioverter defibrillator should be made. And I'll speak a little bit more about that. So there are no good published guidelines on the management of Friedreich's ataxia-associated hypertrophic cardiomyopathy. There are, however, guidelines for the care of those with the better understood hypertrophic cardiomyopathy that goes along with sarcomere gene mutations. So in 2011, there was an updated set of guidelines published by a group including Barry Marin and Dr. Gersh. You'll see in this algorithm that they have put together, they don't even have asymptomatic hypertrophic cardiomyopathy on the algorithm at all, because for those patients, no medicines are currently recommended. Now, in those who are symptomatic, if there's no evidence of outflow tract obstruction, but symptoms are present, the first line is a calcium channel blocker like verapamil. And if that doesn't work, then switching to a beta blocker is recommended. Generally, you'll see that we try not to put a patient on both a beta blocker and a calcium channel blocker at the same time, because those can act together to lower the blood pressure even more than we'd like to see and slow the heart rate even more than we'd like to see. In those who do have outflow tract obstruction, there's a bias towards going first to the beta blockers, because I don't know if it's anecdotally, I haven't seen it proven anywhere, but at least anecdotally that seems to work better in relieving outflow tract obstruction. And then if that doesn't work, either on the symptoms or on the outflow tract gradient, then one can again consider switching to the calcium channel blocker, or instead add disopyramide to the regimen. And if you line up 10 cardiologists, you'll probably see 5 do one thing and 5 do the other. Again, if the verapamil doesn't work, then you can go to this combination of disopyramide and beta blockade. And then if those together don't work, the options are limited, and certainly in some cases, surgery to actually relieve outflow tract obstruction by carving out extra muscle, ablation, which is a catheter-based procedure to decrease the muscle mass by either freezing or burning by catheters, or pacemaker implantation to control rhythms and really take over the myocardial oxygen demand by driving the heart's rate can be considered. So if I've got Friedreich's and a cardiomyopathy, how often should I see a cardiologist, and what testing should be done? Well, that's going to be different depending on what center you're at, but I think universally we can say that cardiac screening should begin soon after a Friedreich's diagnosis, just to establish what is the level of heart involvement from the start. And then I would say that regular follow-up should increase during periods of accelerated growth. So in my world, that means during adolescence. If I was seeing someone every 2 years, I might step it up to every 1 year. Or if I was seeing them every year, I might see them more often, like every 6 months. And then, of course, they should be seen more often also if there's a clinical concern, like the onset of new symptoms or new outflow tract obstruction. Testing that you're likely to encounter when you do see a cardiologist would include things that look at your heart rhythm, so an EKG, which is a 6-second snapshot of how your heart rhythm proceeds, what's the electrical conduction through the heart, and what's your heart rhythm, and a Holter monitor, which is a longer-term monitor, usually worn for 24 hours at a time, to see what's the real range of what your heart rhythm does over the course of a 24-hour day. Now, in every cardiac evaluation for Friedreich's ataxia, some modality looking at the heart visually should be undertaken, and most commonly that's going to be an echocardiogram. That's an ultrasound of the heart. Shouldn't hurt, just takes a little time to get the best pictures possible, and that can give an assessment both of how thick is the heart, is there obstruction to blood leaving the heart, is there that outflow tract obstruction, and how well is the heart squeezing. Now, more and more we're seeing cardiac magnetic resonance or cardiac MRIs being performed, and I'm a big proponent of that, but that's not yet become so widely accessible and available that everyone is getting one, and I'll speak a little bit more to that in just a moment. Finally, whenever possible, we like to try to get a functional assessment, and so when the proper equipment is available, an exercise stress test can be very helpful in trying to help risk stratify someone and really get a baseline of what's their performance status. So to this question of whether a cardiac MRI is really useful, I don't expect you to be able to read this, but this is a section, again, from that recent hypertrophic cardiomyopathy guideline document published last year. And currently those guidelines rarely require a cardiac MRI. In general, if you have a good echocardiogram, that should be enough. However, there are certain aspects to cardiac MRI that are very tempting, at least from an academic or research standpoint, and hopefully one day from a clinical perspective as well. So cardiac MRI really gives us a nice three-dimensional view of the heart that's not limited by the rib cage, it's not limited by body habitus and positioning, and it can really give us nice information about the tissue itself. How much scarring is there, how much fibrosis. They can even give certain agents like adenosine to see what the heart does under stress. It's another modality that can assess how well does the heart squeeze, and we call that LV function. And it also can quantify mass, so how thick is the heart. And it's not just limited to a two-dimensional plane as it is in echocardiogram. And most echocardiography, it can give you a three-dimensional view of how thick the heart is, and you can trend that over time. Of course, further research is needed to really demonstrate whether there's a benefit of using cardiac MR with respect to giving prognosis to somebody, and whether it really helps in risk stratifying a person with hypertrophic cardiomyopathy. And finally, it's not always feasible, even if your insurance company will actually pay for it and you can actually get on a good scanner. If spinal rods are present, some of those are compatible with MRI and some of them are not. But even if they're compatible, depending on how high up they go, the scatter may prevent a good picture of the heart itself. So from a research perspective, where are we at with cardiac testing? Well, recently, a group that had been looking at idebenone actually proposed stratifying patients based upon their septal thickness. So IVSD is intraventricular septal thickness in diastole, and also using ejection fraction, so how well the heart is squeezing. And they were able to do this by echocardiogram, and they thought that it correlated well enough with MRI that you don't have to get an MRI, but can just rely on the echocardiogram. Interestingly, I noticed that they put in there that those who fell into the most severe group of FA-associated cardiomyopathy had reduced systolic strain of the posterior wall by echocardiogram. Strain is something that's not universally performed. It's a technical modality that can be done by echo. It produces lots of pretty squiggly lines and lots of different colors. But there's a lot of intra and inter-observer variability in how strain is performed and how it's interpreted, so I don't think it's quite ready for prime time. But as cardiologists and echocardiographers in particular get better at performing strain and tightening up how well they do it, I think that may be a modality that may point us towards risk stratification and prognosis, particularly in hypertrophic cardiomyopathy. I also wanted to mention that there's a team that's come together, supported by the NIH, to come up with a list of data, not just cardiac specific, but data in any sort of research realm that explores Friedreich's ataxia. And this team have put together a list of core supplemental and exploratory data. So those that are core are those that they propose should be included in all research studies that examine Friedreich's ataxia populations. Those that are supplementary and exploratory show promise, and hopefully will one day get to that core category. In cardiac data, the core elements that they've proposed include EKG data, echocardiography, Holter monitor data, and then some of the outcomes data, like did someone get hospitalized for heart failure? Did they die because of a cardiac complication? Supplementary data, so cardiac MR is still in that supplementary category. Exercise data is even a little bit lower down in the exploratory category. And then many laboratory tests have been proposed, but most still need further validation. And that's an area very near and dear to my research heart. I would love to be able to find simple blood tests that could speak to how much risk someone has of developing a heart complication, or perhaps identifying those who are at the highest risk of a heart complication and when it's proper to intervene with a medicine, perhaps sooner than what we see on an echocardiogram or on a Holter monitor. Some of those tests, some of those simple blood tests are starting to pan out in other populations. So for example, highly sensitive troponins seem to be prognostic in adult heart failure populations, and that's all comers with heart failure. Maybe that'll be helpful in the Friedreich's ataxia hypertrophic cardiomyopathy patients. We don't know yet if it'll be helpful, and so further research is needed before we can say you have to get a troponin to risk stratify every Friedreich's patient. So what about idebenone and the heart? Well, the preliminary results were encouraging, as I'm sure many of you know. So back in 2002, in the open label study, the majority of patients either had stable hypertrophy or even decreased in the thickness of their heart. And in 2003, there was a group that showed at least 10% reduction in interventricular septal thickness in the idebenone group as compared to the placebo group. So we were very encouraged by that finding. Unfortunately, in the phase 3 trial that came out in publication last year, idebenone did not decrease left ventricular hypertrophy or improve cardiac function in subjects with Friedreich's ataxia at the 6-month mark. Now, of course, there are many plausible explanations for why idebenone didn't show a positive cardiac benefit in this study. Maybe the study was too short. Maybe we enrolled patients who weren't the most likely to be positively affected. Maybe the theory's correct, but the dose or the delivery of the medicine is just not adequate. Maybe the endpoints are not the ones that really matter. So maybe even though idebenone doesn't decrease LV hypertrophy or improve cardiac function at 6 months, maybe it's still a helpful medicine. We don't know. But the bottom line is, unfortunately, the study didn't provide that definitive proof of benefit that we had been hoping for. Now, what about this question about defibrillators? Now, again, in the guidelines for those with the sarcomere gene mutation hypertrophic cardiomyopathy, there is a nice algorithm for what risk factors should prompt a strong consideration for a defibrillator. So the 7 risk factors that are traditionally screened for in hypertrophic cardiomyopathy patients include a prior history of a cardiac arrest, prior history of ventricular tachycardia, which is a life-threatening heart rhythm, a family history of sudden cardiac death, a left ventricular thickness at any wall of greater than 3 centimeters, and that's in the adult population, recent unexplained syncope or passing out, non-sustained ventricular tachycardia, so evidence of even shorter runs of a bad heart rhythm, either by Holter monitor or by telemetry. And finally, if you're able to obtain an exercise stress test, an abnormal blood pressure response to exercise is a prompt for considering defibrillator. Now, of course, these are all prompts extrapolated from the general hypertrophic cardiomyopathy population and not necessarily specific to Friedreich's ataxia. So I'm just going to speed through a couple other things. I think I'm getting short on time here. But I did want to mention chest pain and chest pain in the Friedreich's patient. So chest pain is actually a common symptom in hypertrophic cardiomyopathy, and the proposed mechanism of this is an imbalance between the myocardial oxygen supply and demand. So what could contribute to not enough supply or too high of demand in a hypertroph? Well, subendocardial ischemia could be one thing, microvascular disease at the small blood vessel level, and decreased perfusion to the coronary arteries when the heart is trying to relax. Of note, macrovascular disease, so what I mean by that is typical coronary artery disease, plaque rupture in a big blood vessel around the heart, that's not commonly seen in Friedreich's ataxia. Of course, traditional risk factors, family history, cholesterol, a history of diabetes, which can be more common in Friedreich's, may still apply and may still put a Friedreich's patient at risk of coronary artery disease. But I think in most cardiologists' practice, we don't see a lot of coronary artery disease in Friedreich's patients. So that brings me to just this one point I wanted to drive home, that chest pain in a Friedreich's patient does not necessarily mean that you're having a heart attack, and you're going to have to educate the doctors evaluating you about this. So in 2007, there was a new definition for a heart attack or acute myocardial infarction that was published. And by that definition, someone with Friedreich's ataxia who presents with chest pain and a bump in their cardiac biomarker called troponin could automatically be thought to be having a major heart attack. Oops. However, we just published a study this year of 49 asymptomatic Friedreich's ataxia patients, in whom almost half of those asymptomatic patients had an elevation in their troponin level. So if at baseline you have an elevation in your troponin level and then you develop chest pain, which can be common in hypertrophic cardiomyopathy, if you show up in an emergency room, you're at risk for being called a heart attack patient. So where I think this points us is it may be important to establish your own baseline. So ask your cardiologist or your internist for baseline studies when you don't have chest pain. What does your baseline EKG look like, and what does your troponin level look like when you're well? That way, if you show up in an emergency room with chest pain, you'll know if an elevated troponin or an abnormal EKG are different than your baseline, and you may save yourself a trip to the cardiac catheterization lab. Briefly, for those whose cardiomyopathy progresses to heart failure or dilated cardiomyopathy, there are proven medicines of benefit in those people. Those include ACE inhibitors, beta blockers, aldosterone antagonists, digoxin, and then in people who have fluid overload, diuretics. And then other considerations should be made for cardiac resynchronization therapy, which is also known as biventricular pacing, defibrillators. So in addition to the risk factors I mentioned for hypertrophic cardiomyopathy, patients with a dilated, non-functioning or poorly functioning heart also have a higher risk of life-threatening arrhythmias, for which a defibrillator may be helpful. And then advanced heart failure therapies, and I'll mention two of those on my way to finishing up. First, though, I wanted to briefly mention the things that I think that other doctors will want to know about your heart. And again, you guys know this better than most of us. You're often the educator to your doctors of your condition. So the things I think your doctor may want to know is, what does your baseline EKG and troponin look like? What does your baseline ejection fraction look like? Because a decreased ejection fraction does portend a higher risk for things like procedures. What's the degree of outflow tract obstruction you have? Can be anywhere from none to severe outflow tract obstruction. Again, that helps a physician to know what's your risk of heart failure development. Do you have any history of abnormal heart rhythms? And then it's important for everyone involved in your care to know that there is this potential for diastolic dysfunction. So even if a heart is squeezing nicely and is just thick when we look at an echo or an MRI, a thick heart is generally more stiff and doesn't accept blood as well, and that's what we mean by diastolic dysfunction. And in a state of diastolic dysfunction, fluid shifts are not tolerated as well, long anesthesia times can be harmful, and low blood pressure or hypotension should be avoided if possible. What's the perfect storm of fluid shifts, long anesthesia, and hypotension? Scoliosis surgery. So going into scoliosis surgery, your anesthesiologist should be acutely aware that your heart may be stiff, even if it's squeezing well. That doesn't mean you shouldn't go for that surgery, but it does mean they have to be aware and plan for that. So two provocative questions just to finish up. First, if you have Friedreich's ataxia and your heart declines to the point that you're in end-stage heart failure, are you a heart transplant candidate? Well, I can't answer that question definitively because every center sets their candidacy requirements individually, and certainly they have to comply by UNOS rules, but every center has to weigh the risk and benefit of performing a heart transplant and consider the limited resource that a heart transplant comes with. However, I did want to mention that there are now at least 3 reports in the literature of successful, in the at least short to intermediate term, of heart transplantation in Friedreich's ataxia patients. That first one is actually an abstract of 3 in another country, 3 adults. The second one is an adult, I think, in the United States, and then the third is actually a child in Canada who's been transplanted. And again, at short-term follow-up, up to a year or two, they seem to be doing relatively well without necessarily exacerbation of their neurologic symptoms from Friedreich's. Finally, what about VAD therapy? So ventricular assist devices that support a failing heart mechanically have now an expanding pool of candidates. So whereas we used to only use it as a bridge to get to a heart transplant, it's now being implanted for destination therapy where someone can be indefinitely on a VAD to help support their failing heart and get on with their life. They're now smaller and more compact, and there are even pediatric devices developed or in development. So I put out to you, if we can put a VAD in this gentleman here. I don't know how many of you recognize our former vice president who had multiple comorbidities going into his VAD as a bridge to transplant, a successful transplant by my understanding. Then how far off are we from considering VADs in Friedreich's ataxia patients? Again, just as with heart transplantation, it's an individual decision, a center-specific decision and a patient-specific decision, but certainly there are patients with Friedreich's ataxia who may be very reasonable and very good VAD candidates. And there has already been at least one published experience using a ventricular assist device in a Friedreich's ataxia patient as destination therapy. I'm going to stop there because I think we need to leave a little time for questions and a potty break. Am I right, Dave?